everybody, and welcome to another edition of the Food is Health Revolution podcast with my friends Carter Williams, I Select Fund, Ellen Brown from BP2 Health, and I'm Katie Stebbins, the Executive Director of the Food Nutrition Innovation Institute at Tufts University. Welcome, you guys. I'm really excited to do this episode with you because although it probably will be published after the new year, we are sitting on the verge of the end of the year, and this is a great time for the three of us to reflect. And so this episode is going to be an excellent time for the three of us to reflect on the amazing amount of information we learned this year. What do you think?
I think it's a great idea.
Good plan? Okay.
I also think it's the first time that we've had a podcast episode with just the three of us.
Yeah. And I mean, what our listeners may or may not know is that the three of us are friends and we do a lot of this offline. And so it's fun to do it online for the podcast because we spend a fair amount of time chatting. And 2024 was the year we all met each other in person.
Which is just crazy. And I don't think we even linked up I didn't even meet the two of you until this year. And I met Aaron last year. So there you go.
Punctuating what an amazing year this has been. Yeah. So my plan, you guys, that I would like to do, and for our listeners to know, is that we often talk about the food supply chain from soil to cell. That's how we've started describing it at the institute that I run. And I thought what we would do is sort of journey through it with our year 2024, starting on the farm, then going and looking at the manufacturing, production, ingredient side, tap into the third bucket, which is distribution, retail, our friends on that side. I always love where healthcare ties in with that. You guys talking about retail, pharmacy, et cetera. And then we'll go on the consumer side, which we think about the cell. You know, Ellen, this is where obviously healthcare and reflecting back how all these things matter. But to be honest, Ellen and Carter, I think that the healthcare side and the food side connect in all four of these buckets. And I think it'd be interesting for us to try and show those connections, right? Why should healthcare and food is health think about the farm? Why should they be understanding and thinking about supply chain, ingredient production? I think all these things matter. And we could do a really interesting job today going deep into that. So what do you think? Yes, you game?
Yeah, I think it's a good idea. But I do want to add a little bit of context to that, because I think the three of us and the group that's sort of convening and getting larger, right, I think there's been more and more clarity around soil to cell, dirt to dirt, and the need for that to be understood systemically. And so I think this conversation, as you've laid it out, Katie, really does that in those buckets. And I just think it's really important for the listeners to understand that as we enter 2025, that this platform that we've created is really meant to try to build that and bring everybody together around that whole concept of soil to cell.
Yeah, completely. I love how you said soil to soil, indicating that we sort of are birthed out of the dirt and we die in the dirt. Yeah. I read this book once. There was this great line in it. It was like, we're host to all of this bacteria and world our whole lives. And then we die and it eats us. And that's our purpose. I'm like,
I know. Oh. And who knows, maybe we come back. Who knows, right? So
let's start on the farm, you guys. 2024, I have to say, was an amazing year for myself personally to explore the farm side. I had the privilege of starting my year in Switzerland, going to a dairy farm at a World UNESCO site, which was amazing to learn about the world of dairy. I've been to a big farm this year in Salinas. I've been to small farms. I got to meet small scale farmers, both through you guys and through special moments like meeting John Chester from the movie Biggest Little Farm, with his Apricot Lane farms outside of LA. But what I learned from all these people and what I'd like for us to discuss for a minute is when the word regenerative comes up, it's not always met with happy giggles, arms flaring, celebration, going off fireworks. Every single time I had this conversation around the world, what came up was it's nuanced. There is nuance in this conversation that we're not talking about. And while there's some good big concepts in how we want to move forward, we're losing some of the more surgical level nuance to make implementation happen, right? So for instance, what we say for regenerative for one crop might be different for another crop, or, crop by crop, farm by farm, size by size. There's a lot of nuance in the system at the farming and soil level that by using big words, we might be missing. And I'd love to just talk about that a little bit. Carter, especially you, You study systems thinking so often, and just wondering if you also have had this reaction or interaction on the farm side.
Yeah, I think that the implementation of regenerative at times comes in from people who know little about farming, going to people who have been farming all their lives and saying, well, you need to understand what no-till is, or you need to understand what integrated livestock is. And when you're talking to a third generation, fourth generation, fifth generation, they know what it is. It's not like new. And it's sort of like, in a sense, I don't know if this is a perfect analogy, it's sort of like going to a mechanic and saying, I want to teach you what a Phillips screwdriver does. You need a Phillips screw to use a Phillips screwdriver on it. And if I'm the producer, the farmer, and you're saying I'm willing to buy products with attributes in which regenerative is important, then they will use the Phillips screwdriver and make regenerative crops. And so it's less an issue of somebody coming in and saying, we're going to give you these prescribed measures, you need to do regenerative, and you need to do it in this way. Because depending on where you are in this, we've had Matt Moreland on here before, where Matt is, it's better for him, given the availability of cattle, to do integrated livestock than a cover crop.
Right.
And if the CPGs, for example, say, look, I'm trying to achieve this thing, which might be a nutritional density or carbon density or carbon capture, and then just sort of leave it to the producer to sort of figure it out. That's a more natural balance of things. And it is, we're making a shift towards regenerative, so I can understand the pushing and shoving that's going on. But in the end, the producer really is the one who's going to figure out whether he's going to use a Phillips screwdriver or an Allen wrench.
Yeah. And I think the word shift is important here. Someone described it to me this week as a journey, regenerative journey, which I thought was really interesting. And Ellen, as we think about this push towards health and revolution towards health and having the medical community on board with understanding how healthy, nutritionally dense food is made, one of the things strikes me is we talk about this like this is a today thing, right? And not a journey. But the farmers I've talked to, it could take 7 to 10 years in some cases to rebuild soil, depleted dead soils to the point where they can actually produce that kind of food. So the journey of this that everyone's going on, how do we balance, Ellen, that sort of like, I feel like we're talking about this in an urgent way, but we're also not talking about like, this is a long game, right? How do we do that with still getting people at the table?
Well, because I think healthcare is an equally long game. So the same way that we're talking about 7 to 10 years to bring soil back to life, right? Or whatever time frame, it's not 1 to 2 years.
Right.
When we talk about 3 trillion, which I would argue now that we've gotten this new $5 trillion number of healthcare spend, we're probably closer to 3.5 to 4 trillion of this in chronic disease burden, right? Majority of which is associated with metabolic syndrome, cardiometabolic syndrome and disorder. And that doesn't change overnight. Not that kind of movement, right? Maybe like we talk about early adopters, you can take cohorts, folks, right? But I think we have to redesign the economics of healthcare. And I had this epiphany that it's rather parochial, and Carter luckily humored me earlier this week, where I called him and I said, did we ever even know how to be healthy? Did people ever think about how to be healthy? Because we sit here and blame the healthcare system and say, well, we don't even teach people how to, take care of themselves. We just treat them. And that light bulb went off, which was, we never needed healthcare. We needed to keep people alive. Like, you didn't go to the doctor to find out how to be well. You just inherently knew how. And so my point is to get us to a different place, to get us to an economic place where it pays to be healthy and people know how they can, the friction's removed enough. No longer do we have 4.5 trillion tied up in a sick care system, right? People have some choices. I think this is an equally long journey, Katie. And I think the urgency is, you guys, this isn't working. We have a cataclysmic problem, right? The Medicare trust fund is going to fall apart. We can't afford 5 trillion. I mean, You guys, we just updated the number to over 4 trillion right when I met you. I mean, this is like climbing at trillions at this point. So,
well, Carter, I was just going to add to that, just thinking about the opportunity then to do some modeling, right? The opportunity to really think about how much productive land do we need? How much soil do we need to transform into better, healthier, productive soils? What is that going to take? How does that equal out to health? I mean, there's some big system modeling here. I was looking at some data from Jess Fonzo from Columbia over the weekend. She's an amazing data dashboard. I think that showed 1% of America's workforce works in farming, and 16% of our land is actually built for irrigation. And so I think about those numbers, and I think about us proposing a system where there's going to be a drastic increase in demand in domestically produced fruits and vegetables, right? I feel like that's what we're talking about. And I'm just trying to look at those numbers and going, I don't know if all these numbers add up. Like, there's some big modeling and systems work to do here, Carter.
Yeah, I think I would add to that a productivity component. Because if you go back to when we got into limits of growth with, who's the guy in the early 70s that said that the world was going to come to an end?
We're all having senior moments. I can't remember.
But the reality was technology sort of stepped in and we didn't run out of food. And Paul Ehrlich in the late 60s, early 70s said, we're going to reach this crisis. By 1985, everyone's going to be starving and we're all going to be eating each other or something like that. But what was missed,
people, yes, the Soylent Green line, yes.
So what was missed was innovation sort of stepped in. And I think that there were many of those correcting factors. I think that, and so then it's a little bit of an episode, and something that I think we should be concentrating on is giving people an indication of that shift. So there's 600,000 row crop farmers in the United States, 300 million plus acreage. About 80,000 of those are really farmers that have the real mastery of the agricultural process. They can grow, they can do it profitably, they can run their operation and apply the right practices. And so it is important, just as we think about early adopters in technology, to sort of say, if we want to make the shift, instead of trying to do it all at once, the incremental component of it is, let's concentrate on the early adopters first, and let those early adopters sort of take stuff that is, I mean, just go back to your own experience with computers is a good one. Yeah. Like when you first started using a computer or you first started using a browser, some people had the intuition to use it more effectively and then developed new ways to develop that the original programmers didn't understand. And so those are good early adopters to figure out a better way to bring something productive. And then as that sort of evolves and establishes sort of the de facto standards, the what is the component? How much more nutritional will get put in sweet potatoes? Can we come up with a new wheat variety that's got more fiber in it, like Bay State Milling does? Can we work through and use new precision or new filtering technology in Fairlife to come up with a lactose free that also is richer? And so there's a bit of that on the early phase that we should sort of let play in, because it's a concept called turnpiking in economics, because it sort of leaps us ahead, and then think about the fact that, hey, we should pour on capital to scale it once that new design is sort of. And we're in that phase in technology as it applies to the infusion of regenerative, for example, in the cropping systems of and very in particular, we've spent the last 70 years concentrating on yield, and we went from 20 bushels an acre to 300 and change now. In a similar way, we want to start paying attention to taste and nutrition.
Well, so can I just add something there then that I want to bring you in on, Ellen, in that point, which is this shift from calories, this industrial revolution push to produce as many calories as possible to make sure that a country doesn't starve, right? We very effectively designed a system to make sure that there would be calories available. That was a goal achieved, did that very well, right? And so now that we keep talking about, okay, that's achieved, how do we make sure all those calories we're producing are nutrient dense and really good for the body? we're seeing a much slower shift in that narrative and to move over. I wonder, Ellen, how much healthcare is going to have to be lockstep with the food system to really effectively have that conversation for a true systems change. I mean, that's a policy statement, right? I mean, that's a national policy mandate of the country to decide they're going to do that.
It could be, but when I look at the traction that GLP-1s have gotten, that to me shows the, not a pun intended, the appetite of people to curb obesity, to feel healthier, to be healthier. To me, it's a mass acknowledgement that there's a problem. But we've trained our culture that you take a pill to solve a problem when it comes to your health. That's the easy way. That's what you do. So I think there's some natural, and Carter, I'm certain, will have the economic and systems theory to put behind what I'm going to say. But
that's why we love him.
He makes me feel smart when I talk. I just, but I think that what we're seeing economically is that GLP-1s, the way they are priced, and I know we have compounded and we're going to bring the price down, but let's just leave it where it is for now. Okay. That even if we get it down, there's still an acknowledgement that there's food in this equation, that it can't solely be the GLP-1s, unless of course you're Elon Musk, and then perhaps you just say you take the GLP-1s. But I think we all contend and understand. And so that to me is going to drive a shift, right, within healthcare, whether we like it or not. And Carter has pointed this out on the food side and on the healthcare side, that if you shift the dollars into the GLP-1s, that when that obesity starts to come down, right, then you have less food being consumed, right? So there's not an economic impact to the food industry. It has the same kind of effect on the healthcare side, which is now suddenly you have less acute care visits, you have less heads in beds. And so I don't know. I guess I feel like we have some private control here. We don't have to rely on policy.
Okay. I think it's about how do we advocate for the system, right? And also like who's advocating and how are we doing it?
So I'm sorry to jump in, but I was going to build on Carter's point. And
go for it.
So Carter was talking about, he did an amazing job on the food, right? Which early adopter, like where food is sort of moving nutritional, all of that, right? I think we are in healthcare at the earliest part of that parallel. I think food's a little bit ahead because.
Oh, interesting. Okay.
I think food's Greek yogurt. If you ever walk down the yogurt aisle, look what happened there. People wanted more protein, less sugar, right?
Food's ahead of the healthcare system in terms of telling the consumer or indicating to the consumer what might be good for them.
Correct. Just slightly, just ever slightly. And I think it gets back to the fact that there's no barrier between the consumer and the food, cost-wise. So unlike healthcare where
I don't need a referral to go to the grocery store.
Correct. And also your benefits, like you don't just pay the doctor, right? Your benefits pay the doctor. There's a lot of complications in the system, whereas with food, it's pretty much, I mean, look, I know there's layers of subsidies underneath, but I go to the grocery store, I use my card, right? I like, there's nobody, unless let's just, for the majority of people.
Katie, I would just say, let's put a pin in that when we get to the retail conversation, because I think that's really important on the retail side.
On the healthcare side, I'm seeing some early adoption of acknowledgement of some of the bigger health systems that chronic care management, the way we've been doing it, isn't working. And they're saying, hey, Ellen, I think there's something to food. I think there's something to practicing medicine a little bit differently. Let's look at that. And so I think 2025, you're going to see a little bit of a catch up to what Carter just described on the food side in the healthcare space, where people are realizing that there is potentially an alternative path there.
And I sat next to a woman, a nurse practitioner on the airplane last night, who was like, I am dying to learn more about food. She's like, when my patients say to me, do I need more vitamin K? Because I was reading about it. She's like, my response is, I'm not quite sure. And so she's like, but I want to know, and I want to take a class so I can have an answer to that question, which I thought was really interesting. Go ahead, Carter.
So I think that the policy, a component in policy relates to friction. So there are frictional components to this shift, and we are in a moment of flux that people are recognizing that food matters more, or that for the sickest people, the GLP-1s help move them to a new plateau that then allows them to be more receptive. And I think that we're starting to see on the entrepreneurial side, as investors in that area, we always are trying to take out friction, but we're also moving to a bit more of a world where the individual, I think, has a lot more tacit knowledge of what they want to do. They go to the grocery store and they read labels. I believe that the consumer has two price elasticity curves in their mind. They know when they buy Oreos that they're not healthy for them, but they're satisfied with them from a calorie standpoint. And I think that everybody has an innate kind of component that basically says, if I'm in the store and I'm buying for calories, I want this price point. If I'm buying for nutrition, I'm okay with this price point. And there's some differences there.
Interesting.
They want some more trust that if they're buying for nutrition, that they're actually getting that. And so there's confusion. Too many people say, well, people buy what they want to buy and they don't want to be healthy. I don't think that is true in the least. I think that's rarely true. I think that what they run into is the level of friction, which is part of the cost of procurement. Like when you buy stuff, I got to get in my car, I got to drive there, I got to move around the aisles, I got to figure out what's truth. Those are all components that go into the cost of acquisition of your food. And I think that if we rethink that, and a good example of that is when McDonald's shifted to electronic menus, sales went up because all of a sudden people were able to see other things they wanted to buy. I've seen somebody who's got one of these nutrition apps, which there are many of, but he characterized that they're able to cross-sell. So if someone's in the store, they do a label, they look at a pizza, ultra-processed food pizza, frozen pizza, they look at that label and it says, look, based on your profile, you've got whatever, CKD or whatever it is, you shouldn't buy this one, you should think about this other one, but also you should think about this probiotic to match with you. Well, that probiotic's $60 a bottle. And so what we're starting to see is what we may actually see is that once the consumer gets better information, they're then able to spend their money on the things that they want to spend their money on.
Yes, totally. I love that both of you love the retail conversation, by the way. Like, it's so easy for you to go to the third bucket because but what that says to me is that's such an important point of contact and discussion in this, that I want to make sure that we loop back to those, because I have some other additional thoughts on that. I want to close out the farm conversation really quickly. And, Carter, I definitely want to ask you about, as a VC, what are some trends for 2025 you think would be particularly important? One of the things I just want to sort of close out my own thinking on is that I spent this year learning that, there's this nuance of big ag, medium-sized farms, small farms, micro farms, local, big. There's a villainization in many circles of bigger agriculture. There's a love of local agriculture. It doesn't play out necessarily the way that we've romanticized it, for instance. There are good big farms that we need in our food supply chain in order to feed the massive numbers of people on this planet that I don't think we're appreciating and really giving love to. When I went out and visited Tanimur and Ansel in Salinas County, and Scott Grabu, the CEO, spent the day with us, it was such a great lesson in understanding that this system is so complicated. And they do supply a lot of food for a lot of people. And they appreciate that when I loved his description of when it's New England and you guys are having your farmer's market season, we're going to reduce how much we're producing for you because we know it's your farmer's market season. We respect the fact you're going to be buying local. And then when it hits wintertime, guess what? We know you're going to need more of our food or else you're not going to have any lettuce. And so the system, and again, he also says, if there's a local crop failure, and some stores decided they're going to carry local and suddenly they can't, we're here to backstop that. And then there's also the conversations of, you buy at a local farm, you don't necessarily have the soil testing. You don't necessarily know. We've seen stories about water contaminated growing local products. I mean, just all this different nuance of it's not perfect and it's not black and white. It's not like local versus big. And I think in 2025, I would love to see us get a little more nuanced about the system and not just decide that it's one or the other.
Yeah, I think that, and we touched on this a little bit. So Brad Fruth, who's
from Beck's,
from Beck's and the row crop, he said his daughters are going to be involved in improving the quality. They're going to be working up and down the supply chain. They're not going to work on the farm. I mean, you could have 5 people working on the farm all running the tractor, or you can have, now the tractor is automated, and you need to do more soil testing. So you need somebody who can maybe do the analysis on those microbes and figure out what needs to be done, and work with Meriterra on something like that. So the complexity and the specialization required to make that stuff work is complex. It requires more skill, and that to some degree merits size. And the farmers, and we are seeing this, 600,000 farmers in row crop. 80,000 that really understand how to master the forces at bay. Well, they're in a position of the dynamic that we've got an oversupply right now of commodity crops that's driving price down. It's going to put some farmers out of business. And what's going to happen is you're going to see those people who sort of have mastered the forces here really go out and rent that land from other people and increase from a 20,000 acre to 40,000. That's not bad. I mean, it could be bad, but just because they're doing that, that's not bad. And what we need to do is look at Audacious. Audacious is measuring the resulting output, and we're moving away from a practices-based type thing that says do it this way. And instead, if the procurement systems that the CPGs and the ingredients companies move more to we can measure the performance of these things, and we can determine what's going on, and we can sort of leave you alone to figure out the balance. But we do have a mechanism, because Audacious has brought the cost of that test from $2,400 to $100.
Right.
You're going to see, and so what I think from an innovation standpoint, where we're concentrating is how do we move the friction from a horizontal. Right now we have a horizontal supply system.
Yep.
Drive down price as much as we can and get scale, optimizing on process, to one in which we're moving to a vertically oriented for a period of time, in which we're trying to maximize new attributes, not calories, but omega-3, omega-6 balance.
Yeah. And then won't it be interesting, Ellen, when you have a company like Audacious, which is able to really articulate the density of nutrition of what's coming out of the fields. I don't want to say it creates a medical supply chain, like a medical grade supply chain, but it does tend to speak to the medicine in food when, what I mean?
It's necessary. And the one thing I was thinking as you were putting a pin in the farm side is there has been a massive awakening of the healthcare industry around the need for food. And I think our voices have also been instrumental in, this isn't just about food insecurity. It's about exactly what you're talking about, Katie. But I will tell you which is nutritional density and making sure that it is more medicinal, right? If you give somebody empty calories, whether it's a piece of kale or it's a cracker, I mean, clearly there's some metabolic differences there, but if there's no nutritional value to it other than calories, that's a problem, right? And so that has to be addressed. But I will say one of the things we really do have to solve for is the distribution, not just the identification and measurement of that and standardization of that nutritional density, the codification through something like Audacious, right?
Yeah.
We had Jim Jones on the other podcast, and he
from
talked
FDA.
about the front of label. Correct. He talked about some of the initiatives of the FDA, which of course I want to have him on this podcast next year.
Yeah, he's great. He preceded me on stage this year, and he's fantastic.
He's fantastic. But all that to say, our biggest, I think, other than the educational side, when people get on board with this, they just want the health system wants the food and they don't know how to get it. So we have to figure out a way to distribute. And this is a systems issue that Carter and Aaron Martin and you and I have talked about a lot, which is we have to figure out a way to connect the local regenerative farmers with the healthcare delivery system, right? Because they want that access to that medicinal.
Totally. But I also want to point out how you just phrased that, even local regenerative food. I want to point out, we can't feed everyone healthy if we're only going to use the words local and regenerative added together as the gold standard. And there's such a nuance in that. And there's a lot of complications in that and learnings to be done. I think we need to start we need to start referring to the new version of the health of the food system. We can't keep calling it local regenerative for everyone to go, oh, that's the gold standard. I think we're doing ourselves a disservice by doing that.
Very valid, very valid. And I get myopic on it in part because I'm thinking health system, food program for 100 people for the year or 500 people for the year. And to your point, this needs to be this needs to be a population solution, not, oh, the local health system down the street wants to do a program for cardiometabolic syndrome, right?
Well, think about Mass General. I mean, I'm here in Boston with Mass General and Brigham and all these hospitals. If all of those hospitals combined were going to feed all of their patient base, local regenerative, they couldn't. And so you have to rely on and have a conversation with and be partners with bigger operations to supply good, nutritionally dense food at scale. And I think we just have to be so careful because by the way, I love local farms. I love regenerative farming. I love all the practices. I mean, that's sort of my jam, but I'm not naive about the fact that we have to stop talking about it like that's the thing, like that's the holy grail. Yeah.
There is, in the complexity of this, I think that from a systems side, we've got to think about the general concepts of more nutritional density. In terms of the positioning side, there is a practical component of marketing and such in which we've got to sort of shift the community. And I think we will be in a space at times where we do need to give it a label to make it easier for people to comprehend.
I know we like shorthanding things. I totally get that. But the problem is when we shorthand things, we also villainize what's not in shorthand. We have to be very, very careful about that. I would not want to disenfranchise people who want to be a part of the solution who suddenly don't feel like that label isn't them.
Yeah.
So let's go. Let's shift a little bit to manufacturing and processing. Because this has been a really interesting part of the component of this as well this year to learn about. I don't know about you guys, but I talk to a lot of farmers who say, in order to make more money, in order to create better regional economies on the local side, we need processing production. We need a better infrastructure in our country that calls out that relationship between healthcare and local. But their point being, we don't have a good national handle on regional processing facilities that allow us to have like what Commonwealth Kitchen does here in Boston, which is regional co-packing, like smaller farmers being able to have regional processing, slaughterhouses, all sorts of things. So there's that side of it. How are we going to accurately create processing infrastructure in this country? And then the second part of it is, if you read the headlines, we had a lot of recalls this year. If you're a doctor and you're a patient and you're a community and you're trying to get everyone to start eating really healthy, right? How do you handle, in this side of this, the health and safety comes into this, all of the recalls on healthy fruits and vegetables and meats that we keep seeing in the headlines? And I wonder if we need to have better conversations with the health and safety side because it's a headwind that's going to be problematic.
Yeah, you sort of dropped one in there. I think
we can go to the first one, which is processing infrastructure, or we can go to health and safety side. But I don't think we should exclude the health and safety inspection side of it. Imagine being a doctor telling someone to go eat more carrots and then like they eat a bunch of carrots and it's on a recall. I mean, I'm saying that's an extreme example.
Are bringing new crops in because one of the reasons we have certain crops we have is because we developed Roundup in a trait-based control so that you had the genetics in the crop matched with the herbicide that allowed you to cut down weed pressure and produce crops with less cost. So when people looked at things like heritage grains that might have more expression of protein or something like that, it became very expensive to farm them because you didn't really have a good way to do herbicides. Now we have laser weeders and other things. And so we're seeing a different kind of mix of those things. So that then means we have new entrepreneurs showing up, large and small, who are developing these new crops. And when they have a different IP, is referred to identity preserved crop, and they show up at the ADM mill that says we need to process 100,000 bushels, and you want to process 2,000 bushels. So it's a stopper. So there are things like Mad Agriculture that have stepped in, who are doing these smaller facilities. And we've done this before. We did it in the automobile industry, and in the 70s, all steel started moving to Japan because they could produce something cheaper. But then we moved to just-in-time manufacturing. At the same time, we developed blast furnaces that were electric instead of coal burning. And all of a sudden, we could do mini mills. We could do smaller mills that were cost effective. You didn't need the scale, and that they fit with what we were doing in just-in-time manufacturing. That is below the radar here that's going on, and add to it, because we got different kinds of processing, specialty processing, row crop processing. So there are different components to this processing. Automation. I mean, the conversation is that everybody's imagining that the changes on immigration policy are going to give up our availability of low cost labor. And what they mean by low cost labor is below minimum wage. Well, nobody's getting paid minimum wage, even if they're and people are getting paid $30 an hour, whether they're a citizen or not a citizen.
I learned that when I was in Salinas. Wow, that was an eye-opening lesson in California agricultural policy.
So we've got a lot of goofy things going on in there that I think is part of the ground game of trying to reorient the logistics.
That neither side of the aisle is accurately talking about.
The
talking points up here are totally doing disservice to that.
They don't even have a clue. I mean, it's not even, because part of the game is moving so fast, but the capital markets are not fully aligned.
Yeah.
So the notion of private equity, and we're just starting to see some of the private equity guys come forward to basically show up at the table. We're working with one now, showing up at the table says, I think there's an opportunity infrastructure here, but they're naive in many ways to actually what it is. And they're leaning on us to sort of say, can you be our Sherpa here a little bit in this conversation? And I think that there's a lot of realignment there, and it does relate to there still are details. I mean, it's cool that you can now produce it this other way. It's cool that I can get a heritage grain from North Dakota delivered to New York City on a regular basis in a consistent scale so that I can baseline it in my product.
Yeah.
But it still needs to meet the same quality standards that the other parts of the food system. And so those challenges of food safety and stuff, you still have to deliver at that level.
Well, and I think it's about trust, right? Because the other conversation here, and Ellen, this is kind of interesting in terms of we're trying to build people's trust in a healthcare system. We're trying to build people's trust in a new version of a healthcare system, maybe multiple new versions of a healthcare system. And we're trying to build people's trust in a new way of eating and thinking about food and a new way of engaging with the food system. And just as we get headlines happening in the healthcare system of, someone had a surgery and it was botched, or someone got this treatment and they got the wrong drug, or whatever it was. And there's things that cause us to mistrust the healthcare system. We're trying to push a new paradigm and having to deal with some of those headwinds as well. And I'm interested in your thoughts on how we navigate some of that. How do we mature the conversation while acknowledging that a lot of this iterative process is not going to be perfect, right? There's going to be bumps in the road. And how do we bring the healthcare world along understanding that? It's kind of like getting people to drive self-driving cars, I feel like. There's a little bit of it's going to be bumpy, but we can do this.
I guess I've had an epiphany in the last 6 months that I'm no longer trying to bring anybody along. It was very freeing, which is that the system we've created is very effective at it is largely effective at doing what we want it to do, which is keeping people alive when they're acutely ill. And that's right. And that's kind of what Carter and I talked about. I'm grossly, oversimplifying it, but right. I mean, you go back in time and there was bloodletting, right? I mean, it's like we've been pretty, it's like keep people alive. And what we're talking about is something that doesn't exist today, which is helping people understand their health. And there is no system for that today. And what I think the big mistake we've made in our industry, and even at a policy level, is that we've tried to force the health of people on top and into a sick care system where the economics are misaligned. And so there's been this like bizarre, sort of these like, I don't know, broad swath attempts of desperation by policy to say, well, you will cover a well visit every year, and you will cover a mammogram, and you will cover this cancer screening, right? Like just these very like sort of like piecemeal things that you layer in. And you can't
maybe
have
they
it
don't want an extra layer, which is, and you will cover a patient's entire basket of healthy food.
So I think, I mean, you guys know this, is I've really evolved my thinking to believe what we more need to do is figure out the system. We need to figure out what people actually need to help them be healthy, like from a knowledge, from a food, from all that. And then we just need to figure out how to extract a certain portion, redesign sick care in terms of its funding. So like we've talked about insurance, really redesigning the insurance side. And I think this is where the new administration may actually be helpful on it. I mean, there's a lot of things about the new administration that could be helpful. I don't want to sound like that, but there, in the previous term, there were these short-term insurance policies. And I think that mechanism could be a mechanism for creating like a catastrophic plan. And so you take a true stripped down, right now we have this like bastardized version of a catastrophic plan for people. It's just weird, right? Just call it what it is, make it what it is, and then give people the extra $300 or $400 a month. Either make the HSA more broad in terms of how it can be used, right? And then strip the stuff out that holds people back, right? And gives them a little bit more democracy and license in making decisions with their healthcare dollar.
So as you're talking about that, Ellen, and this bucket also includes the food manufacturers, which is CPG. I mean, this is food manufacturing. This is these guys. And earlier this year, you guys were both at my annual meeting and with all of my industry council members. And you said something, Ellen, at the meeting that we've talked about before, which was really profound to me, which was a lot of the growth of the modern day healthcare system happened as the modern day CPG companies also grew with a lot of the products that we have now. And your point was, we have to, as we grew together, we also have to, I don't know if shrink is a good word because no one wants to think about shrinking P&Ls. We have to transform P&Ls together, right? And it's interesting to think about that as a together though, right? I mean, I love working with my friends at Nestle Global Health. They do medical nutrition. Those guys are incredible. They totally get it. It's how thinking, and then Carter, you mentioned Bay State milling, like thinking about, flours that have more protein in them. This is an interesting space of thinking about healthcare and the CPGs working together, because neither of them wants to lose money. They're seeing them. They could both potentially lose money with GLP-1s. They could both potentially lose money with the woman on the airplane again last night coming back from France was like, do you have any idea how many surgeries happen because people are obese and on food related diseases? They're like, she's like, I don't know that my healthcare system wants to lose that money. And so she's like, if people aren't obese,
$8 billion is going to disappear out of their revenue.
That's what she said. She's like, how's the healthcare system going to stay alive if people aren't sick? So this is like, isn't this the $1 million question, right? They don't want to shrink together. They want to evolve together.
Clay Christensen studied this well and basically said, when you get into these moments in time, the incumbents lose.
Yep. And that's what I believe.
What happens is when refer to the y-axis, we're now focused on nutrition instead of yield. Mm-hmm. We're focused on nutrition instead of calories. We're focused on nutrition instead of sick care. So when those change, the people who are running healthcare and the people who are running CPGs are not product innovators. They're process. They are Lean Six Sigma types. Right. They're operators. There is a way in which they deliver care. There is a way in which they deliver food, and they are perfect at reducing that cost and doing the value engineering. And they're extraordinarily good at that process innovation. They don't think about problems from a first principle standpoint. They don't think about they're not equipped and trained or or experience, whatever. Maybe I'm making a criticism of them, but they're just not the people that sort of think in a first principle kind of way of like, oh, wait a second, I could eliminate. They don't even know. There are doctors in that system that fully don't understand really that you can cure type 2 diabetes or effectively cure it.
So if there's a lot of question marks on both of those sides of the equation, is there a benefit for them to sit together, or do you think a broken system and a broken system sitting together are not going to come up with a better system?
What you I'm being a little geeky on this, but it's referred to as sort of modularity in a system, and that there's a point in time where you could say there are thousands of things that need to be done in the process of moving this all along. There are thousands of little steps, and they're all individually separate. But then there's a concept of modularity where you basically say, no, these 20 things should really be done together because there are a lot of feedback loops. You got to do this and you got to do this and you got to go back and redo this. And so that reshaping of the supply chain, and I think it will, there will be, and there's like, personally, I think that healthcare and CPGs go away in a bit, and grocery retail steps in and modulates nutrition and real food. Like, why couldn't a grocery store, or why couldn't somebody at that part of the value chain basically say, I'm going to help you optimize your nutrition or help you manage that, and I'm going to do it more with real food because the ultra processed thing's slowing down a little bit. And I'm going to step in and be that person, and I don't have to have an MD to do it.
So in 2025, what do we think are going to be, or do you have any predictions on some interesting indicators that might come out of this really interesting, complicated relationship? What are some little things what are some canaries in the coal mine in 2025 that you guys might be looking for in this relationship?
In the manufacturing,
in that big CPG, big healthcare relationship, what are some canaries in the coal mine? We had some obviously with the GLP-1 P&L returns on both sides, but what are some things you think might be interesting to look for?
I think Hims and Hers coming out, they did it a little bit, coming out with nutrition flank, but with real, I mean, they came out with it in packaged nutrition, but I think somewhere down that path, or somebody like Lilly, or I don't know if that's a canary in the coal mine, 'cause it's pretty big, but Lilly coming out with an integrated food solution and maybe partnering with Walmart.
Yeah. And Nestle coming out with a GLP-1 line of foods, which now Marie Callender's, if you saw it, Marie Callender, the company that makes Marie Callender's.
Kirkland coming out as a regenerative GLP brand.
Yeah, which we'll get to the Carter's favorite Costco conversation. So I think, go ahead, Ellen.
Well, no, when you talk about, I mean, honestly, I think Carter hit on the ones that I would jump on, but I kind of step a level up back and say, I think food wins here.
Go further.
Food owns health. Health doesn't own food. Period.
I add one thing to it, and it would be interesting, that I think that food doesn't realize that.
I think you're right about that. But food is more agile than health is. The food system is actually more agile than the healthcare system.
Totally. Yeah. Because it's directly linked. There's so many reasons. I won't even go into.
It's so much more accessible. Yeah. And although it's still a big cruise tanker oil ship in the ocean trying to turn quickly.
Why do you think I'm committed to the council that you have? Because that's where health is.
So interesting. Yeah. So it'll be interesting this time next year to reflect on some of those continued opened up conversations.
But food catches on.
Food doesn't know it yet. When I have conversations with food, it's still very confusing to them. It's like, what? It's like,
we're gonna be doing more of that this year, aren't we?
I was going to say, as soon as they start catching on, it doesn't take much. Their degrees of freedom are greater, so that they can move quicker to adapt. Where healthcare is stuck in a regular
insurance risk, Katie. Food could, and see, that's the mistake. That to me is where the mistake was made on. And I think you're going to probably jump to retail, maybe not. But when I look at retail grocery, I think the big mistake that they made was they didn't meet people where they were. They tried to shove healthcare, a traditional healthcare system, into the grocery store.
Yeah. So let's go there, because that's interesting. Because will retail be where the food industry gets its education? Like, will retail have to manage up and teach food that they're actually in control of the healthcare system?
I think so.
I think so, but I've said that to them and had tried to engage that conversation. I've gotten nowhere.
But I think farming. So interestingly enough, I think there's a level of that on the farming side opportunity too. Like we didn't hit on that. So like, for example, Erin's program, we worked with her and now she has a contract with a health insurance company that not only does she get paid for the food program, right, which we call a little bit of a care model, because it's not just handing out boxes, right? There's education, there's some health aspects.
Yeah, she's health coaching everyone through what do you do with that box of food.
And I say that on this podcast because I think it's really important that, like, I'm tired of hearing about just handing people boxes of food. Like, that's right. We got to do something more here. But what's interesting is, on her end, we were able to get a contract where she's getting paid for the food, and then she's going to get paid for the health outcomes that the food delivers if she hits them. And the idea, checks are going to be written back to the farmers as clinicians in that. And so if that economic model starts to help happen a little bit, then that to me is another place where on the farming side, they can transform into more of a care delivery system.
Economics of this change there are, in a $100 bag of groceries, food is roughly, call it $100 per person per week. So in a $100 bag of grocery, $7 of that is agricultural products. The rest is everything that happens above the farm. Processing, packaging, trucking, QA, getting into the retail, marketing the retail, all that. So that's one thing.
Mm-hmm.
And then if you take the 20 million sickest people in the United States, they bring $30,000 a year of healthcare costs.
Mm-hmm.
And so whatever that is, you call that $93 times 52 plus 30,000. And that's the slop of cash that's available to realign. And even, I'm going to go just to confuse the matter more. If grocery retail is not going to step in and take over nutrition,
so
grocery
go back
retail
to that.
could be disintermediated by somebody else like Uber Eats or something. I don't think it's going to be Uber Eats.
Well, look at what Instacart's doing. I mean, Instacart's really aggressively leaning in some really interesting ways on food as health.
There are other things. There's a lot of room, and from a venture standpoint, I think we're behind on. From an investment standpoint, is recognizing our job is not to come up with new food per se. It's to reduce the friction of the shift of the business model.
And looking at new ventures that can do that, right?
Yeah, that whole area from the $30,000 per patient on the sickest to the $93 per week that is taking stuff off the farm and getting it to you to eat. That whole area is open design space to re-engineer the food supply system, whatever, nutrition.
Yeah. Well, no, Carter hit on it. I mean, it's relativity, right? I mean, 30,000 annually versus your grocery budget. Imagine redistributing a portion of that. So let's go to that 30,000. And let's say that on average, I mean, look, an average cardiometabolically ill person is 24,000 to 50,000 a year in spend. Like, that's how much their healthcare costs are on average. That means that you've got people that are costing $500,000 to $1 million, and then you have people that are costing, nothing, right? Imagine a grocery store taking financial risk on that population for their cost of care by giving them food, and then they get to share. Let's say you saved 15,000 of that 30,000, right? And that grocery store took the financial risk instead of the insurer or instead of the employer, right? Whoever it is that's taking the insurance risk. And now let's say that food saved $15,000. Well, that's a heck of a payday for grocery to have $15,000 on one person versus trying to chase pennies on the dollar of the grocery side. So that's why I'm saying it's ready for food.
It would be interesting to run the experiment with a food chain. It'd be interesting for like a Kroger or Walmart, or
we're ready to have the conversation.
Yeah, to like have them do this with their own employees, which I mean, when you're,
We don't need clinics. That's the thing. All these retail outlets said, I need to have health clinics at my grocery store. That's what people want.
yeah,
No, people want to. It's what Carter and
they
I
don't want to be
first
sick.
found. They want to walk in a grocery store and have it be hard to eat unhealthy. Like,
Yeah,
give me good food that tastes good, that's affordable, right?
yeah.
It's just healthy. I just walk in, I buy my stuff, I go home, I eat, I'm good, right? Like, it's not rocket science, but
And
we've
if
made
you
it
go
really
to, you know, I haven't seen this yet, and I don't know why, but like if you go back to like Tesla's got no dealerships. It's sort of entered into the market saying I'm going to provide, and it's the number one car now or something.
You just buy it off the web.
No, but look where they went. They went to the mall.
They went to malls.
Because they said, you know what? People go to the mall to shop, right? They don't go to the, they don't, right? If I'm shopping, wouldn't it be nice to just look at a car while I'm at the ball? But, shopping, they met people where they were.
Yeah, so there's an opportunity here to like, there's
Yeah.
a lot of room to rethink that part of the business model.
There is. I just think we have to acknowledge the fact that we've had this conversation in council meetings, and the retailers are also clear that, like, look, the margins of running those stores is thin, and they're basically a rental space. And they're saying, look, here's a warehouse with shelves, and you can rent that space, and it's not up to us to say what goes on the shelves or not. Our business model is based on people renting from us. So how does the retail model shift? Because they have to make money too. And if they're making money on cheap calories, then they don't have an incentive in the system.
And GM didn't have an incentive to move to electric cars.
Which goes back to my $30,000, to Carter's $30,000 and my point about saving on that revenue. That's where the money comes into play. And I don't disagree with you. Retail, it doesn't have to be retail. It could be the food system. And it goes back to Carter's point of, Kirkland, where you own I've gotten stuck on Carter's point about hims and hers and this closed loop system. I think I say it at least every few days. I'm like,
I've heard you say it many times. Yes.
Because it's true. Because healthcare is sort of this closed loop system that doesn't work. So it's like we need a different system. I just like the term.
So there's a world in which we have to model all those pieces out, right? I mean, Carter, more than 7% of that equation needs to be going to the farmer, because at the end of the day, if farmers aren't making any money, the system just sucks, right? Like, farmers need to be valued.
Yeah, I mean, there's margin in that system that could move over to motivate the farmer.
That can move over. And then we have to think about the margin on the retail side, because we can't just say, well, great, we're going to make more, that's a cost in the system, not to mention the other costs that we don't talk about very often in the food system. And I'm sure it's in the healthcare system too, which are call it men, but middle people, right? There's a lot of brokers in the system along the way who all have their hands out. I mean, the food system is wrought from soil to cell with the brokers along the way, both good and bad. And that's like
an important. I mean, distributors. What is Amazon? It's a distribution system,
right? It's a distribution system.
So distribution systems matter.
So let's shift then to the consumer side. Where is the power? The fourth bucket, the consumer in the cell. What power does the consumer have in all of this? And we often say the food companies, the retailers will say, well, the consumer's got to drive demand and change because they've got to want this. I think that's a false bottom argument, because the consumer, just like when I did cybersecurity, I didn't think it should be on the consumer to make sure that all these products they were buying were cyber secure. And you produce millions of products with the same password, and it's up to you to change it, and then I'll get hacked and wonder why. Like, there's got to be protections in place for the consumer. And this is the same argument. The consumer in this, what is their role and what is not their role? And how will the consumer drive change or not drive change? I mean, how does that work?
Every new change, you got to have early adopters, and those early adopters start making the shift, and then they educate the next chunk. So some people started using Netscape browsers, and now everybody uses Chrome. So I think that overall, I believe inherently people will want to be healthy. There's a lot of friction in figuring out how to get there. The people that see their way through that friction first, we really probably need to concentrate on them and then let them what we actually want to do is we want to accelerate those early adopters so that they then become the referenceable set that help explain to the nuances of the shift and the adoption. And
yes, but we got to be careful about that, because that's also the place where misinformation happens. It's the place where the protein craze happened to an extent that was not helpful. I mean, so it's a tricky space.
I have a strong point of view on this. I think you guys both know this, which is I think that healthcare is one industry that the early adopter curve is challenged because the majority of people don't have access to their healthcare dollars.
Right.
And
it mutes out, it euthanizes, the healthcare system euthanizes early adopters.
It becomes this sunk cost that you just have to let go in life, which is so horrifying.
Well, but what that means though, is that you can't get the masses, because the only people that can early adopt are those that have the disposable income.
Right.
To try all these new things.
Above and beyond what they're already paying into healthcare.
Correct.
Yeah.
Correct. So that's why I drive everybody crazy, because I say we have to just leverage the programs that allow you to redistribute the money.
Yeah.
So, but there are programs. See, people give up on it, and I'm like, no. There's actually a way. And so then I go to, well, who's investing the money on people's behalf? So you guys talked about middlemen. I actually think that brokers and benefits consultants are one of the biggest friction points for innovation in healthcare benefit design, because they're financially incented by the health plans. So they have incentives to keep employers with certain health plans or move them to certain health plans. They're not looking at what's the best. There's always the good guys, right? But largely the incentive is completely misaligned. And so they tend to be a barrier to the kind of innovation that we're talking about. But I think there's starting to be some momentum in places where there's some pockets where we can jump in there, right? And I've talked about those. So I've actually spent the year really trying to unpack where those pockets of opportunity are, those little cracks that we could go in and extract the money and say, okay, it's ours to spend in a new model. Okay, it's ours to spend and they're in all little tiny places. But to Carter's point, so I look at healthcare a little bit different. Instead of looking at early adoption at the consumer level, I look at early adoption at who owns the premium dollar. And then I say, how do I then put these new models into who owns the premium dollar, right? Because that's where I can truly innovate. And if I can, so then who are those early adopters? And they're in all different buckets. They're employers, they're the government, they're health systems, right? They're health plans, right? There's different ones. And so you pull out those early adopters of, I realize that I'm not doing a good job of managing the medical cost of my population. There's Houston, we have a problem, right?
Yeah. If I'm reading you right, Ellen, and what you were talking about with the retail side, I think about how much money gets taken out of my check every month to go towards my health plan. I'm never sick. My husband's never sick. My kids aren't sick. We go to the doctor so infrequently. It's ridiculous.
Yep.
And I would love it if they said, you know what, Katie, you are so well. You guys are in your 50s and you're so healthy. We're going to allocate this money and reimburse you for your grocery costs because clearly you're doing something right. And, send us just like we get like $150 health club benefit. There's you know what? We're going to give you $100 a week, food voucher because you're so healthy. Congratulations.
We can't do that because we are in a death spiral. If you look at health insurance as an insurance product, as an insurance vertical, health insurance is in a death spiral. And there is no underwriting mechanism to stop the downward spiral. There's no actuarial way to stop that. But
that means there's no actuarial way to incentivize health.
Correct. Meaning you can't redistribute exactly the way the system is now. And so that's why you have to look at a way to control the premium dollar yourself in the kind of model that we're talking about, right? and invest it that way. You still have to have a catastrophic insurance plan, but
Yeah.
we've bastardized it so much.
But I would love to be able to sign up for like Aaron's healthcare and be like, hey, I'm going to put my money into Aaron's healthcare plan, which is going to allow me to buy fresh fruits and vegetables and get some general nutrition counseling, because that's what my family needs. And that's what I'm going to spend money on.
And now you've had favorable selection because people that want to buy your health plan that's centered on food, right? They see the inherent value of their health. Carter, you have something to say.
There is going to be a tipping point, and the tipping point occurs when the economics start shifting and enough different people sort of see what's going on. And then we have some extinction level events going on right now. We have GLP-1s are an extinction level event for hospitals in terms of revenue.
Yep.
We have the Senate moving on separating the PBMs out from healthcare.
Say what PBMs are, because we might not know.
Benefit management. So United Healthcare is sitting there with 70% of its profits coming out of their pharmacy benefit management program, and that is going to be separated out. And then we have, in terms of pharmacy benefit management, we've got food coming in and saying we can do some of the things that those drugs can do.
Exactly.
So we've got
and farmer becoming pharmacist. The farmer going, and I got nutrient dense food out of my farm that you'll pay a premium for.
We've got to look at the 20-year-olds and notice that there's a segment that's distinctly losing weight, so that they are not eating the wrong stuff. So I might put there's several extinction level events for the incumbents here, and those are all sort of happening at the same time in other periods of time. So we have a crescendo of a wave hitting here. The question is it going to get to 20 feet high or 30 feet high? And if it gets to 60 feet high, then things start tumbling down. And we're getting pretty close to 60 feet high in terms of the pressure point.
If GLP-1s hadn't come along and had this breakthrough, do you think that we'd be that close to a crescendo? Is it that big of a moment?
I think it's that big a thing. I mean, I love looking at history in terms of healthcare. Like one example is the H. pylori in terms of ulcers, and that really sort of came together in 1995. And if you look back in history and sort of say, how many was this a new novel idea? And he spent 10 years, 15 years trying to persuade everybody that bacteria caused ulcers, and finally it came together. Well, I ended up running into a little bit of a historian on this, and I've looked back, and there are like 6 or 7 times where somebody postulated that ulcers were caused by bacteria back to like 1880. I ran into a doctor who actually studies this a lot, and he said it's worse than that. It was like back into the 1700s when we didn't even know what bacteria was. People postulated that it was. And we run into these periods where like HIV, immunotherapy. Immunotherapy is a byproduct of the AIDS research in the 80s. We didn't understand really the sort of the factors of how viruses operated. And were it not for AIDS appearing in the 80s, we likely would not have immunotherapy at this point.
And what's interesting is those are very healthcare related pieces of the puzzle. The GLP-1s suddenly pulls in the food system in a way it's never been pulled in before.
Sorry, hold on one second. The other thing on GLP-1s is we haven't even opened up the next layer, and that is its effect on
addiction.
No. Well, addiction is just one component, but inflammation.
And inflammation.
We are completely different in terms of understanding the inflammatory markers, and really, why did we start paying attention to inflammation so much? Because of COVID. The fact that COVID has a vascular inflammatory effect.
Yep.
When it was originally perceived as it would cause lung response, it actually affects the bloodstream of the vascular system and through inflammation in a way that causes a lot of trouble. And the whole area of inflammation is opening up. So we haven't even gotten into that issue, which is good. And if we tackle inflammation, we're going to be in a whole nother plane of science that I think is equivalent to what we learned in immunotherapy.
I agree with you. And I think it brings me to one of my last topics, which is the diagnostics market. And so alongside here is our ability to have a conversation with a consumer/patient on what's going on. We have a precision nutrition working group on our council. One of the things I see is I'm a little dissatisfied by the momentum, the movement of the diagnostics market in this. How quickly can we know those things, Carter? How quickly can we know, right now, again, it's the discretionary income that people have that can afford these sort of very high-end diagnostics, right, off the functional health market to even get a little bit of an insight. But there's going to be a lot more that the consumer is going to demand to walk in the doctor's office and say, I need to know more. I need to know more real time. What's going on in this machine called my body?
So we had this really interesting conversation when you bring up diagnostics. And it was an unexpected conversation in Vegas when I was at Health. So I had two physicians and one of the leading EHR, right, electronic health records expert in the country together. And we had a guest who is the chief medical officer of a cutting edge diagnostics, right, the full body scan technology. And this interesting aside with that, when we talk about early adopters, is he actually explained to us that they have people that come in there that are virtually on the edge of Medicaid that find the money to pay for these tests because they see on social media that they should get it. Just wow. Okay. So I just have to throw that out there that it blows this whole idea that,
only the rich and famous are doing it.
Right. But here was the interesting conversation. So the two physicians were like, this creates so much confusion for patients. They go get this test, they go to their doctor, and their doctor's like, yeah, that's not out of the reference norm. Like, it's fine. You're fine. They think they're dying based on what they get back. They go to the physician, and then they set it's like they're down this diagnostic rabbit hole that they didn't need to go down, according to the doctor. Now, here's the fascinating thing. When we shifted the conversation, and I said, okay, let's just pretend that our objective here was not to stay alive with our premium dollar, but our objective with our premium dollar was to stay healthy, was to get well and stay healthy. Now, what do you think of that test?
Right.
Whole different answer. Yeah. So this goes back to my
different way. Can you go into some more detail there?
Yeah. So in the sick care system, it makes no sense to figure out all the things that are maybe indicators that maybe something's going to happen in 5 or 10 years. Like, it's like, that's all hypothetical, right?
And your references are around illness. Your references aren't around health.
Exactly. Yeah. But when you change it and say, I'm using this as my reference, my starting point, right? My baseline. And I care about my baseline, because every year I'm going to check on myself with that baseline of my full spectrum of health, right? And if I'm financially aligned to remain healthy, now everything shifts. And now it makes sense.
Like my longevity baseline, or
like longevity, all the then a function health that looks at all the different dimensions of your health, right? Not just the brass tacks basics.
Right.
Now it changes the game, and it makes sense to understand, oh, you have that little tiny bit of plaque over there. We need to look at that every year. But in the sick care model, is it blocked? No, it's not blocked. So we don't need to do surgery on that. And it hasn't hit a point where we need to give you a statin.
Yeah, the entire set of language is different. The entire language set around that conversation. And by the way, I had a doctor who said to me once, by the time you go to the doctor because you're sick, you've very likely been sick for a long time. You just finally got to the point where your systems couldn't overcompensate anymore, and you finally had to go get seen.
Absolutely, Katie. Absolutely. So take A1C. So if I know, right, people don't even know their A1C. It's not a standard test, usually, right? Until you get to a certain age and you have that's insanity. A1C is one of the most critical markers for cardiometabolic syndrome disorder health, right? Like, and yet we don't wear continuous glucose monitors. We have no clue what food does with our own bodies, right? If you took A1C and said, oh, my A1C right now is 4 or 4.5, right? And then every year I had it tested and next year it was 5.5. Wouldn't you pay attention to that? Who cares that diabetes isn't until 7? I'm creeping up. I was here and now I'm creeping up.
But this is where the intersection with healthcare and food gets really interesting, because the consumer might not be telling the food companies, I want to demand these different products necessarily, if they don't know what they don't know. But if a patient suddenly understands what it takes to stay well, their conversation at the grocery store is very different, because what they're trying to preserve is their health. They're not trying to just get better.
Yeah, I'm going to take us a slight ditch in a different direction.
Totally.
So I think the diagnostic Function Health, which we've mentioned, is both a thing and a company, and Function Health is now delivering, as we know, we've all done.
But we can reference functional health.
No, but I mean, I just want to dive into what they're doing there. So some people are like, well, what is Function Health doing? A lot of times Function Health shows green across the board. What they are doing is they are also building the reference library of the control.
Correct.
The MRI folks are doing a reference library of control.
Correct.
And once you have control against out-of-band condition, you can start doing AI work. You can start doing more. I think that
and that's the real value.
You look at PubMed. PubMed has a whole bunch of studies. When you look at nutrition PubMed, the data is crap. I mean, when you look at most nutrition studies, they don't do good washout periods. There are a whole bunch of reasons why. But PubMed itself, and when we talk about the reproducibility crisis and some of the things that went on in terms of people not being truthful in their research, PubMed is full maybe with 50, 60, 70% of the data there actually not being good data. And we've heard that from Dr. Joe. And so then people are coming in with AI and modeling that and building it off of crappy studies that really aren't good RCTs. So I think in a lot of the research is on sort of white males or Caucasians. And so even the diversity of some of the data has got some problems. So I think we got a lot of homework to do.
Yeah.
In terms of if we want it so that you can walk into the grocery store and not make a bad decision, that means we have to understand what a good decision is. To get to what a good decision is, there is some work that really needs to be done. And then if we think about it, the degree to which people are not getting the standard of care in healthcare, there are people that don't get a large fraction of people, I think, do not get what someone would consider the baseline standard of care, because even the doctors have a hard time getting educated. So there's going to be a lot of opportunity for both AI to step in as a care delivery mechanism to help normalize that. But we also are going to start discovering that we were wrong, that ulcers are caused by bacteria. Those same kinds of discoveries have not yet been made in terms of like the degree to which the gut microbiome is actually perhaps better or easier to understand than we think it is right now. There's a lot of work there to be done, which I think we're going to start seeing accelerating, which may very well just eliminate whole fields of healthcare, because in the same way that we recognize you should treat ulcers with antibiotics, we're going to start. I have a feeling we've got a few more of those discoveries on the horizon because of the better diagnostic tools we have, the better AI tools, the better analytical tools we have.
Well, so you just hit something that if somebody was listening, I'm not sure they would understand the gravity of the point that you made, which is you talked about the fact that we don't really have the reference data. And so
we've got bad data in the reference data and don't know it.
Correct. And
people have lied on their research.
Right. Not only that, but we don't even have sufficient data. I mean, period. But yet we are trying to use AI to diagnose and treat. And in a sick care approach. So it's like you're just stacking it up. It goes back to the point of the power of diagnostics isn't just about, which I know is, Carter, that's why you brought this up, but I'm just going to reiterate it, is that Katie and we initiated this conversation around diagnostics more on the terms of, I want to have a baseline, I want to own my health, right? I want to go from there. You're making the point too of, we actually need all of the data sets that would come from people doing that diagnostic testing, right? Imagine if everybody went out and got this, we would have this massive amount of data and information that would inform us in a whole different way. And then if you tied that with how healthcare was delivered, it would give you a completely different lens in all of this. So I think it makes the case for diagnostics a much stronger case versus where we stick today in the sick care system, which is like, I kind of don't want to know what I want to know because I just need to wait until it gets so bad that it's treatable. Other than that, it's a waste of my money.
And what's interesting, Ellen, in that conversation, because I can see where, there's arguments of, well, N of one data and it wasn't done in a controlled way. And, you're going to send your data in. However, I'm going to Quest Labs to get my blood work done, whether I'm doing it through Function Health or I'm doing it through my doctor. I'm going to the same lab with the same lab techs who are drawing the same blood in the same way, and the same lab is analyzing them and sending the results to just two different people. And so I think we're not acknowledging the fact that there's a few labs in the mix who are doing all of this work right now, and they all have protocols that work for all of it.
Yep.
And why isn't interoperable? It seems to me it could be interoperable and it could be used across the board because the quality control, it's all quality controlled from the same two or three companies.
That's an aspect in assay, yeah.
You're not relying on Function Health to have the standard of care. You're relying on Quest Diagnostics, which has it in spades. Yeah.
So I'll also take this again in another ditch, is why are aircraft safe? Because when an airplane crashes, they didn't used to be safe. We go to the nth degree to understand why it is. And I've been involved in these crash investigations, and you'll go back and find a work order from 20 years ago in which somebody marked that it didn't mark that the sheet metal stock should have been stretcher plate instead of rolled. So you have no idea what that means, but in the context of the design, that was an error in terms of that some industrial engineer made a mistake. But we go through that level of detail of root cause analysis, and people are like, well, why would you do that? That's so much effort. Well, in healthcare, if you were to do that and sort of could build some weight behind the fact that, choices that were made, and we sort of know this. I mean, I don't want to say it's not obvious. So right now, it's like you shouldn't have eaten all that stuff in your 30s. But pre-diabetic is a thing that we need to pay attention to.
Yeah.
Bob Lustig says. So the kind of anal retentive root cause analysis and consistent remodeling of that.
Yes.
It's something that we don't really have in our system that I think is I think about the research that we're doing and the work that we need to do, even in terms of the investments we need to do, is the human body should be able to operate as it needs to do. We're trying to discover why it does. Evolution got us here.
Yeah.
And we're trying to get there. And I think the opportunity for investment and opportunity for research in AI is really to build those longitudinal data sets out more strongly so that we can hit the next horizon of food as health, nutritional analysis.
So I think if we've done anything in this hour plus, you guys, so we've done a few things. We've named some spaces for innovation, by the way. So the innovators and the startups and the people in that space listening, I hope that people have seen all of those pockets of opportunity across the 4 buckets of the food value chain, including all the way to the human and healthcare. I think that's really important. And being someone who loves innovation, I hope that people get that loud and clear. To you guys, what I'd love to close on is, all right, 2025, what are some things you're going to be listening for? What are you watching? And I think that'd be great to convey to our listeners. I know that the arc of innovation and change is long, so a 12-month cycle is almost insignificant, but it's also significant. So to both of you, what are some things that you're going to be listening for as we go through 2025?
We got to figure out what the balance is between RFK and Musk a little bit in terms of the public discourse and whether we're going to see a shift in agriculture and such. We're going to see a lot of pressure on agriculture with the commodity system causing economics to work out. So we're going to see some trouble there, and which may lead to opportunity to more specialized crops. So specialized soy, going into better feed conversion ratio in poultry, for example. We might have a marked change in there in the ag system. That's real important. On the food system, I think at the CPG level, it is really the food science area. I am a CPG. I've been value engineering everything. Am I got a lane change over and start thinking not just about cost, but thinking about taste and nutrition at a different level and its implication into healthcare. I think on the healthcare side, I'm looking for the people who are going to be the first to recognize that their revenue is at risk. $300 billion. The GLP-1s aren't going away. The GLP-1s are going to show up in multiple variations. It's not just going to be about diet. It's going to be about inflammation control. It's going to be about pain relief. If you have less inflammation, you have less pain. You're going to start seeing the GLP-1 platforms sort of emerge. You're going to see PYY come in. You're going to see some other shifts coming in. You're going to see it moving to tablet form. You're going to see its costs going down. And I think that there's things flying off that flywheel that are going to cause, and even if there's going to be some negative effect that pops up, higher incidence of cancer or something like that's going to show up, and there's going to be an opportunity to rethink how the level doses we're doing in GLP-1s. Yep. It's not going away. It's
early days. If you innovate anything, you're going to have, this is the fuzzy front end, right?
And I think, there's also going to be, I think on the consumer level, I think we're going to reach a peak level of backlash where older people are going to realize that there's an opportunity for them to live longer. If they make a shift, they're going to be encouraged by their grandchildren to make that shift. I think that the sense of prosperity that may be a little kick in our heels that's going on right now with the new administration, can we just think about this world a little bit differently? In a positive way? Independent of the administration per se, I just get a sense of people just have sort of a positive shift, and it's we've been such in a crappy position for a while. Let's think about things a little positively. That I think that's all got to sort of move in a constructive dimension rather than a destructive.
Interesting. All right, I like that. Ellen, what's 2025? What are you listening for?
I'm going first in 2025 because I don't want to follow that.
Look, you deferred to Carter.
When we do this for 2026, I go first, Katie. Carter, I go first. Sorry.
All right. So noted, my friend. So noted. But you did. I just want to put you did defer to him to go first.
I punted. So I'm going to be myopic on healthcare for a second and say I think that the administration has potential to blow up healthcare at a very foundational level. There are multiple very pivotal foundational elements of healthcare at question right now because of what's going on. We're talking, Medicare for all, or we're talking the PBM industry blowing up. There are so many of those types, the employer market, there's so much that is under the microscope that actually has some bipartisan support and then with the administration that's being put into place, I think healthcare is very vulnerable in that regard. And so to be honest with you, I think healthcare is going to miss a lot of what's happening. So Carter, as you just described, all of these things that are happening that are going to have a downstream impact on healthcare within, let's call it 12 to 24 months, and it arguably faster, but let's just say it's that kind of tsunami effect that it's coming, and then all of a sudden it's there. I think as it's building in 2025, big time, from my experience over the last 3 decades in healthcare, I think we're going to completely miss it. The big leaders they're too focused on using AI to fix things. I also think that the most recent issue, really the emperor's clothes being revealed with United, this whole sort of epiphany of everybody that when you peel the door back, there was an AI tool that's been used that's denying 30% of claims, like that really, right? And then you see just the anger and just, vitriol of our country against health insurance. There's a lot of reeling that's happening from that. But again, in true healthcare style, we're missing the forest from the trees. And right, it's like, we're going to stop doing claims denial. Nobody goes back to what I said before, which is we're in a death spiral.
Yeah.
Right? If you are managing the risk, if you are an insurance company and you manage risk and you get into a death spiral, you have to fix it. And if you don't have tools to fix it, you got to look at the root cause, right? And here's the beautiful part: if you're a homeowner, if you're a homeowner's insurance company, you can't mitigate hurricanes.
Yeah.
Right? If you're a health insurance company, you could actually partner with the right players to reverse avoidable disease, of which I would argue at least 50 to 75% of our healthcare cost is related to, when you really get down to it. So what I'm watching for is opportunities on the food side, for the food side to step in and say, you know what? I'm whether or not people are healthy anyways, so how can I get into this game, right?
Yeah.
And I'm watching for the early
How can I make money on this game?
Correct. And then I'm watching for the early adopters in the healthcare industry at large, the very traditional bureaucratic, saying, I think there's something here. And I want to try and dig deeper in that, and I want to see if there's not a model.
Yeah, I love that.
And then I really personally want to professionally drive. I want to find those people that see that we need a healthcare parallel to sick care, who want to build that, because that could be anybody from food to healthcare to somebody totally unrelated. We need that.
Yeah. And for me, building on both of those, my lane is economic development. It's the worker, it's the jobs, it's the productivity of our economy. And if I'm hopeful of anything coming off of this election, it's that the focus on the economy and potentially on the worker will allow us to translate some of this into, quote, the health of the workforce.
Yeah.
And how we position and show real numbers and real data and real opportunities on productivity. Again, if we want to reshore, you can only reshore with a healthy workforce. So speak a language of the people in charge, frame the opportunities in a language that is relevant to today. And one of the things I certainly know from my 27 years of working in economic development that I've always said is that sick people don't work, literally and figuratively. And so if we want to build the strongest economy in the world, if we want to build the strongest military in the world, you can only do that with the strongest people in the world. And you don't do that by subsidizing and fueling systems that are killing people.
Correct.
And there's got to be, when you talk about, Carter, you talk about the word reckoning a lot. There's got to be a reckoning in this, and I think the conversations around PFAS and microplastics in the body and detrimental pieces there, the anger around the healthcare system and the insurance system, and people wanting to, this vote was around, I want to reach middle upper class. I want to take that little foothold I've got and keep going. The young people who I mentor and talk to are like, you know what? I voted for this administration because I think they're going to help me get a little wealthier. And I want that. I want to be a productive, wealthy worker in this country. And so I think the nutrition, health, food fields have an opportunity to join in that and say, let us be your partner in this. Let us show you how we can help you create a healthy, productive economy, and might just get us somewhere.
I just want to say, I am so excited and happy that we met.
Same goes for all of you guys.
I mean it. Like,
yes.
A whole nother meeting, but
there's a whole other meeting. But
fantastic that we not only did we meet, but now we have this platform. Like, I just look at 2024. I'm like, this is friggin' fantastic.
Well, and I have to give a nod to Carter here because, Carter, you and I met last fall. a year in 20.
Oh, that's right at Hatch.
We met at Hatch in 23 in Nebraska, and you and I just hit it off immediately. And through you have introduced me to Ellen and to all these people who we just love. Zoe, who's become a friend, and Harriet and Aaron, and like all these incredible people. And I'm so grateful. 2024 for me this year has been the year of new friendships and new relationships and a lot of new beginnings. And you are one of those pivotal people who has introduced me to so many new communities now that I'm really grateful. Your generosity of spirit and how you open up your relationships. I hope everyone who's listening knows that that's one of the things that we can all control and we can all do, is introducing our networks to other networks, so that we can all create more good together.
Non-transactional convening, non-transactional conversation. And then I always say that Carter is the Kevin Bacon of food and healthcare.
Yes, we're all 6 degrees of separation from Carter Williams.
Well, so a thing we do need to concentrate in 2025, and that represents the people who listen to this podcast. We have several WhatsApp groups that are very active in food is health, in farming. I think that my motivation here is to expose the information that we do have to that network and have that network bounce back with 100 times the amount of information saying this is where the opportunities are, and let that to some degree reverberate.
Yeah.
And really sort of accelerate the next step, because there are people who understand the food. They have seen part of the picture. There's great at the end of Infinite Corridor at MIT in Building 2. There's a picture of this giant elephant and 6 or 7 people with blindfolds on touching it, trying to figure out what it is.
Right.
We've got sort of a good community of people here that are touching a part of this. And the more that we can sort of cross-communicate, I think is going to just give everybody in this particular community an opportunity to advance what is important to them.
I love that. So in 2025, everyone stay tuned for lots more episodes, lots more conversation, lots more guests. We have a whole bunch of people we can't wait to have on the show. People are starting to email us and saying, I want to be on your show. And so I think we should honor all of those requests. And so to Ellen and to Carter, happy 2024. Let's go screaming into 25 and let's make some stuff happen. What do you say?
I'm in. Count me in.
Cheers to you guys, friends. Happy New Year.
Happy New Year.